I'll try not to move too much around so I can stay in the thing, but definitely make it informal, and feel free to ask questions at any particular time during the talk. So Rebecca asked me to talk about functional GI disturbances, and probably the reason she asked is because approximately 40 to 50% of every person in this world has functional GI disturbances, and when you look at the Orthodox Jewish community, you're probably up somewhere about 80 to 90%. I'm not sure why that is. I think I like to blame grandmothers on that a little bit, but I'm not really 100% sure. But it's certainly genetic. And so I'd like to give everybody an idea as to how we sort of think of functional GI disturbances a little bit, so that may be able to put things in a little bit of a perspective, because it can be somewhat all-encompassing. Can we move forward on this one?
No, it's on the computer. Sorry.
That's it. Awesome. So I'm going to talk about functional GI disturbances, but let me give you a little bit of a background first. So the way the intestine works is a series of muscles. And to work normally, each muscle has to work in a nice pattern so things move smoothly through the intestine. There's only two things that everybody has inside their intestine. There's stool and there's gas. And so what's supposed to happen is when you go to the bathroom every day, the muscles will work very nicely, push out everything that's in there, and everybody's fine. If those muscles don't work perfectly well, you'll have problems. And the problems will be either bowel movement issues, meaning problems with constipation, problems with diarrhea, or both, or gas issues, meaning you're going to the bathroom and you're not getting the gas out, so you end up with a backup. So either way, you end up with some complaint. Now, in addition, you have to know that the intestine is a neurologic organ, no different than the brain. And in fact, if you know there are certain what are called neurotransmitters, meaning transmitters that transmit information across nerve cells, and the only places that they are in the intestine and in the brain. So the intestine is a neurologic organ, and so each one of those muscles are connected to each other by nerves, and each one of those muscles are also connected to the brain. And so there is what's called a brain-gut axis, meaning a connection between the intestine and the brain, and it goes in two directions. So that everybody sort of knows that when you're under stress, your stomach could hurt. You know, you have stress, you have diarrhea, you're about ready to take the SATs, everybody's in the bathroom. So that's when the brain is going down to the intestine. But the intestine can go up to the brain too. And so oftentimes you'll see as a list of symptoms from intestinal problems includes headaches, lethargy, and so these are intestinal manifestations of a functional, of brain manifestations of an intestinal disorder. Not only that, the children who have neurologic problems will almost invariably have GI disturbances. And again, it's just related to the fact that the brain-intestine connections aren't working perfectly well. So that's sort of a background for all functional GI disturbances. And so we basically classify that as somebody who's got intestinal problems, where it doesn't affect their health. They complain all day long, but they're perfectly healthy. You could do blood tests on them, you could do colonoscopies on them, they'll all look fine, yet they're complaining all the time. And it's not a one-time proposition, it's a chronic disorder. It doesn't necessarily mean that you're complaining all day long, but but you have frequent episodes of abdominal pain. And there are certain things that trigger it, we'll get to that in a little bit, but oftentimes it runs in families, it's chronically, and so that oftentimes I'll see a kid who, who's complaining about stomach issues, and I ask about the family, and they'll say, oh yeah, the grandmother has stomach issues, the mother has stomach issues, the uncle has stomach issues, and I'm saying to myself, what do you think's gonna happen? I mean, it's all somewhat genetic, and for which the etiology is unknown, meaning we don't know what causes it. There are varied symptoms, meaning most of the time you have abdominal pain at some point, otherwise how would you know that you have stomach problems? But there are variations on the theme. And when you're dealing with kids, I always sort of joke a little bit, and that is the kids don't read a textbook. So you could, say adults, they have we call constipation predominant, or they have diarrhea predominant, or they have something. Kids could have all variations on the theme. And it's something just to sort of understand that, it doesn't have to fit exactly into the textbook to be able to fit under the broader category of functional GI disturbances. So one of the most classical one is irritable bowel syndrome, and since you're having to talk about it next week, I'll maybe make you very smart about what's going to happen next week. But you have to understand there's two thoughts about irritable bowel syndrome. They're the people who are very rigid about making the diagnosis. And so, in fact, there's what's called the Rome criteria, which are criteria that have been made as far as people, very smart people, deciding how to classify functional abdominal disorders. And there's what's called irritable bowel syndrome, there's called nonspecific irritable bowel syndrome, there's constipation, there's dyspepsia, and they all have fancy numbers, is H2A, H2B, H2C. And those are very, very nice when you're trying to do research. But when you're trying to deal with your own personal stomach issues, or when we're trying to help patients, I think I'd like to classify them all as functional GI disturbances, but that's a long word. So I use the term IBS in that, and that just basically I use that to classify almost all functional disorders. But there are people who are purists who say, well, if you have bloating and vomiting, you don't really have IBS. And so you'll see I'm going to use those terms interchangeably. There are those who are more strict about it, and so, I mean, they're probably right, but again, I think it's easier to classify them. So when you deal with functional disorders or IBS, there obviously has many impacts on many different people. You always involve the family, because the people are complaining all the time about it. There's a pediatrician if you're dealing with kids, or an adult person. There's nurses and psychologists and all that kind of other stuff. And they all impact on and are important in handling and helping people who suffer from IBS. So here's basically an example of how it sort of moves from different categories. So IBS can involve can happen in any age. Obviously, I'm focusing primarily on pediatrics, but again, it does affect adults as well. But the earliest is colic, and we'll get into that a little bit later on. But colic is basically, kids young in the first month or 2 or 3 of life who are irritable and cranking all day long. And I oftentimes, I am not necessarily going to classify them as having IBS, but if I see a 2-month-old who's irritable and cranking and gassy and all that kind of other stuff, and the mother says, oh yeah, I have a bad stomach, and my grandmother has a bad stomach, and my great-grandmother has a bad stomach, I say the likelihood of this kid growing up to having the same thing is probably pretty high. But oftentimes what will happen is the kids will get better, and then at around 6 months or so, they develop what's called chronic nonspecific diarrhea, which is diarrhea that can go on for a year or 2, and they go 3 to 6 times a day, and they're perfectly healthy, it doesn't bother them, but the kids are having multiple frequent bowel movements. And then those same kids get a little bit older, and then they develop constipation. And then, in fact, when they get a little bit older and become adolescents, they just complain about the stomach all day long. So that's how you could see that these are the same disorder. Oh, thanks. It's the same disorder to a certain extent, just different manifestations at different age groups. And so it's important to understand that, it's not like they develop 4 different diseases. It's the same chronic functional problems, and it just manifests itself somewhat differently. In adults, or older adolescents, we sort of classify IBS as really three distinct disorders. There's sort of IBS constipation predominant, IBS-C, and then there's IBS-D, standing for diarrhea, and then there's an IBS nonspecific, which is really an alternating between constipation and diarrhea. So that's really the adult sort of varieties where they can be classified very simply into different categories. But typically, kids will swing from one category to the next. So you'll get somebody who, who basically has constipation for 3 months, and then all of a sudden swings into diarrhea for the next 3 months, and back and forth. And it can be, obviously, you're going to treat them differently. And so and you're thinking you're having two different diseases, but in fact, it's the same disease, quote unquote, but it's just different manifestations. So here's somewhat of a list of associated symptoms in people with functional disorder. And so gas, bloating, nausea, we'll talk about nausea in a little bit in a second, vomiting, those are really sort of upper intestinal symptoms, whereas obviously diarrhea, constipation is lower intestinal symptoms. And then there's the non-GI symptoms such as fatigue and headaches and sometimes urinary symptoms, which we could talk about if you want. So they're all just different manifestations of the same underlying problem. As far as trying to understand what is going on in these patients, it's multiple the problems. So there is the motility problem that I discussed originally, which is that the nice normal pattern is not working perfectly well. But why that is not completely understood. Then there is what's called visceral hypersensitivity, which means that your intestine is super sensitive. Now, so you have to understand what hurts in the intestine. I could go into somebody's intestine while they're awake even, and carve my initials on the inside, and it wouldn't hurt them in the slightest. But I put a little gas in there, and they're in agony. And the reason that is that the pain sensation, the pain fibers, are on the outside of the intestine. So that when you stretch the intestine, that hurts. So there are three things that hurt a lot in the intestine. There's if you have gallstones, right? If you have a stone there, it blocks this duct. What happens? The duct gets stretched out, and it hurts. Kidney stones, same thing. You have a little kidney stone there, and then a very tiny ureter. It stretches out thing, and you're in agony. And gas. Those are the three things that stretch out hollow organs, and that's what hurts. So on top of that, their patients are seemingly maybe a little bit more hypersensitive to those stretchings, and therefore they complain more with the same amount of gas that may be in there. There are thought to be psychological factors. Again, remember I told you that the brain and the intestine are connected. And so if you have a sensitive intestine, the same degree of stress may cause more discomfort than not, but the stress can do it. So there are psychological factors that are involved. My personal belief is that most of the psychological factors associated with IBS are secondary, meaning if I walked around all day long with my stomach hurting you, I'd probably be a little cranky as well. So similarly, I think most of the problems are going from the intestine back up to the brain rather than the other way around, but there are certain patients for whom there's enough psychological issues going on that until you address those issues, you're not going to get the intestine better. So the interplay exists. Remember I told you that the intestine is a series of muscles, and to work normally, each one is connected by nerves. Those nerves send messages to each other through neurotransmitters. Those neurotransmitters exist in the brain and the intestine, in fact, more in the intestine than the brain. And there may be an imbalance of those, causing the motility to be messed up. Nobody is completely sure about that either. And then there's some thoughts of cytokines. Cytokines are, we'll go into the discussion that you may have next week, but cytokines are released with inflammation. When you have inflammation in the intestine, it releases cytokines. Cytokines are proteins that are released by the intestine, and they can affect the way the intestine works. So that sometimes you get what's called post-inflammatory IBS, when after an inflammation or infection, all of a sudden, somebody whose stomach didn't really bother them before now bothers them a lot. And that's how Crohn's and IBS are related. So you'll hopefully hear about that next week. But ultimately, at the end of the day, the bottom line is it hurts. And so and you need to address why it hurts. And there are many different factors that are also contributing to the pain that's there. I wrote a bunch of them here, but they're not all, it's not an exhaustive list, and it's really primarily, I don't think these are causative, meaning I don't think that diet necessarily causes IBS, but if you happen to have a sensitive stomach and all of a sudden you start changing your diet significantly, I promise you your intestine is going to hurt more. So, which brings me to the next thing, and that is we know that there's some contributing factors to IBS. For instance, if you have a child, remember the 6-month-old child, now all of a sudden, it was perfectly fine, all of a sudden starts having diarrhea, and they're going, instead of going once a day, they're now going 6 times a day. Every mother and father is now worried that the kid is going to be dehydrated. So what do? They give extra fluid. What do you think happens to the diarrhea with the extra fluid? You have more diarrhea. So again, excessive fluid intake has been associated with continuation or perpetuation of the diarrhea in these children. That's one. Second thing that happens is we decide there must be something in the diet that's causing it. So they start eliminating the diet. And the intestine, I say this to the college patients, intestine is not made to have 1 meal a day starting at midnight. It's not made to not eat healthy. It's not made to just drink milk all day long, and it's not made to not drink milk all day long. Intestine is made to sort of have a well-balanced diet. So if all of a sudden you take an intestine that in general is a little bit sensitive, and you start taking away things from the diet, specifically dairy as an example, what's going to happen is you're going to make the diarrhea or the symptoms worse, whatever those symptoms may be, whether the constipation, whether the diarrhea. In fact, what Stanley Cohn did in way back in the 1970s is they didn't really know what IBS was in those days, but there was a favorite test that only GI people saved for select patients, and that's called the 72-hour fecal fat collection, which is you collect stool for 72 hours straight. All the stool you got to put into a container, and you measure what's going in by diet, and you measure what's in the stool, and it's a great screening test. No one does it, but it's a great screening test to find out what's wrong with the intestine. And what you do is you measure fat. And so what they were taking all these patients who were having this diarrhea, and nobody knew what was happening, why, and they did the 72-hour fecal fat collection. But because they wanted to make the test really extra sensitive, they told them not only take your regular diet, take extra fat into your diet, so they could really measure what's coming out the other end. So all these patients who were having diarrhea for 3 months, 6 months in a row, went to the doctor. The guy said, here's the container to collect your stool, take extra fat on it, and all of a sudden diarrhea stopped. And they had nothing to collect because they were gone. And so they realized that by decreasing the fat, you're actually making the diarrhea worse. And if you go, now I'm not saying take extra fat, but that just emphasizes the importance of trying to maintain a normal intestine, a normal diet in this setting. So other factors that help motility. First of all, everybody knows that when you have a little baby and newborn, and you feed them, as you're feeding them, they have a bowel movement. Now it's not like the food you just gave them comes out the other end, but what they have, as we all have, is what's called a gastrocolic reflux, which means you stimulate the intestine, the stomach, and the intestine, the colon, gets stimulated as well. So you stimulate the stomach by putting food in there in the little babies, and they have a bowel movement. Well, that reflex, like all other reflexes, goes in both directions. So the same thing happens if, for instance, you're constipated. If, for instance, you're constipated, and the colon gets all stretched out of shape, it sends a message right to the stomach. And the stomach doesn't empty well, because why? It's going to empty. There's a traffic jam past the stomach with all the other thing that goes on there. So what happens? The kids vomit. So the kid's constipated, but he comes to see me because of vomiting. And that's because of this gastrocolic reflex, which is going in the other direction. And so you can utilize that to sort of help the intestine. Obviously, knowing that if the intestine gets stimulated, meaning feeding, the intestine, the lower colon is going to get stimulated. You could try to use that to sort of help those who are constipated, as an example. Physical activity. Again, remember, in general, the thought process with these patients is that the normal motility of the intestine isn't working very well. That's genetic. I can't do anything about that. That's why, I say, at least to my Ashkenazi Jewish patients, everybody has that. The Sephardi maybe not, less so, a little less so, but still the same idea. It's a genetic tendency. I can't change that. There's only one thing that can change that motility disorder, and that's physical activity. So that I encourage everybody to be active. Now, the little kids, not a problem, but when you start getting into college and beyond, if all of a sudden they stop becoming active, their intestine is going to work very well. I say to my patients that the hardest part of the intestine is 10th and 11th grade. And that's because of the teachers, for all those teachers that are here. But the intestine does not do well if they're sitting doing homework at 11 o'clock at night. Because they're sitting, they're under stress, nothing's happening, nothing's moving. And so when they be studying for the SATs, they're going to be in pain because of that. So physical activity is extremely important in sort of helping maintain normal bowel pattern. And of course, emotional and psychological factors for the reasons that we talked about beforehand. So now I'm going to get into some of the specifics of different manifestations of what I call IBS or functional disorders. The most common is constipation. The most common in the world is constipation, whether we're talking about younger kids, older kids, or adults. That constipation is due to several factors. The number one factor is generally an underlying tendency for the muscles not to work very well. So then you get constipated. Once you get constipated and you're not going regularly, the rectum gets stretched out of shape to hold all the stool that's in there. When the rectum gets stretched out of shape, it's like a muscle, like any other muscle, doesn't work very well. You now end up with two problems. Problem number one is the muscles didn't work well when they started off with. Now they don't work well when they're all distended. So you have to address each one of those issues. So that, as an example, patients come in with abdominal pain. They go to the emergency room because they're in severe pain and someone's worried that they have appendicitis. They do their workup in the emergency room. They do their x-rays or CT scans or whatever you do. They say to you, no, you don't have appendicitis, you have constipation. Take Miralax and go home. And that gets you out of the emergency room. 3 days later, you're back in pain again. Because the Miralax will clean some of the stool out, get you better for the short term, but it didn't deal with the chronic problem. So either you go back to the emergency room or you find yourself, say there's not appendicitis, I gotta deal with this. So you have to know that there are two issues. There's the immediate issue to sort of clear it out, and then you can deal with the chronic issue. So this brings me to my advertisement, which is I think Miralax is a terrible medication. I don't use it. That's not true. I probably use it twice a year, 3 times a year, but I don't think it's a good medication. And the reason is because very few people have pure constipation. The only people who have really pure constipation are the 2-year-olds who you're trying to toilet train. They don't have nothing wrong with their intestine. You're trying to toilet train them. They're giving you a hard time. They withhold. They get constipated. Then you could treat them as constipation. But most people come to see me not because they don't say to me I'm constipated. They say my belly hurts. Well, why does the belly hurt? The belly hurts because it's distension. It's stretched out of shape, right? Remember the muscle, the pain sensations on the outside. And why are they distended? Well, they're partially distended because of stool, but really what they're distended about is because of gas. Because if they're not getting the stool out, they're not getting gas out. So they're backed up, mostly with gas, and that hurts. So if you got them to have a good bowel movement, but didn't get the gas out, they're going to feel just as lousy as they did before. And that's where I think some problems with understanding how Miralax works makes you understand why it's not a good drug for most patients. And that is the way it works is it causes malabsorption. It draws fluid into the intestine, and it draws gas into the intestine. And then if you take enough of it, you come out the other end. So when you use it for a clean out for a colonoscopy, it's a great medicine for it. When you're using it because you have so much stool, it's coming out of your ears, yeah, that's a great medicine for the short term. But then you got to make the patient feel better, and they got to get gas out. And that's where it doesn't become a good medicine. What's good for that is fiber. And so fiber is sort of a healthy way of compensating for an intestine that doesn't work very well. So basically, you need to sort of address the immediate issue. If they have a lot of stool, Miralax is fine, or other laxatives. I tend to use other laxatives. But then you need to deal with the long-term issue. And the long-term issue is probably best dealt with diet and exercise and eating healthy and fiber and all that kind of other stuff. So that's where it's very, very important to deal with, if you're dealing with, to understand that this is not a one-time problem. This is a chronic problem, and you need to deal with them chronically. Otherwise, you're going to not do very well. And there are some long-term consequences of not treating constipation appropriately. Recurrent abdominal pain. So abdominal pain happens, lots. Many disorders can cause recurrent abdominal pain. Inflammatory bowel disease, which is Crohn's and ulcerative colitis, can cause abdominal pain. Ulcers can cause abdominal pain. Lactose intolerance can cause abdominal pain. By the way, lactose intolerance causes abdominal pain because of gas. Again, it looks identical to irritable bowel syndrome, which is gas pain primarily also. IBS, celiac disease looks exactly like everything else in this world. In fact, I always tell patients that you have a multiple choice test in medical school, and one of the choices is celiac disease. You better check off yes for that one, because it could do anything. But it can look like recurrent abdominal pain as well. So when you have somebody with abdominal pain, the idea is you want to make sure nothing else is going on. They do some blood tests, whatever it is. You could check for a few things, and then assume that it's probably IBS, and then deal with that, because again, the problem is it's probably gas pain, and then you want to deal with that ideally with fiber or something along those lines. The toddler's diarrhea, which is what I would talk about as sort of the second presentation of an age group in children, is children anywhere from 6 months to 3 years, painless diarrhea. There's no bleeding, they're growing beautifully. They couldn't care less about the diarrhea, except they get some diaper rashes from time to time. But everybody else cares about the diarrhea. And so those patients, in general, may not need any treatment whatsoever. They're perfectly fine, they're growing fine. You know, they go a lot to the bathroom. But they do, as they get older, develop constipation. And so once they start developing constipation, then it hurts. And then you don't want them to suffer. But the important things to do is obviously keep them eating regularly, regular diet, don't restrict milk. We oftentimes will use fiber as to regulate the bowel movements, which, just so that you know, fiber is not a laxative. It says it's a laxative on the bottles of fiber. The reason it does that is because the company wants to sell it to you. And since constipation is the most common disorder in this world, they write laxative on it so they can buy it. But in fact, it's not a laxative, and it works much better if you have, for diarrhea predominant IBS. So fiber is good for just about anything that ails you, but certainly for the patients with diarrhea, fiber is very, very helpful. And then let's talk about colic, which probably I see more patients with this on a regular basis than anything else. And that is babies come to see me because they're irritable, they're arching, they're not feeding well. Most of the time they're growing fine, but it's just a bad situation. No one's sleeping at night, everybody's upset. Most of the time, they've already been on either breastfed, the mothers are now off, or everything else. If they're not breastfed, they're on several formulas already. They're oftentimes on medication for reflux. I'm going to talk about reflux again in a second because that's my pet peeve. But really, what colic is gas pain, and it's gas pain because the muscles are immature. Remember, the muscles are a series of muscles. They have to work in a nice pattern. That pattern doesn't work well in people who have irritable bowel syndrome, and it also doesn't work well in little babies because the muscles are immature. just like we all know little babies spit up 100 times a day, we don't spit up 100 times a day. And the reason they spit up so many times is because the muscles lower down in the esophagus are immature, and so they spit up a lot. So too the lower intestine doesn't work very well, and they get colicky and gassy and uncomfortable. And if we were to get them to have nice, good, regular bowel movements, they'd eat better. And so it's important to try to break the cycle of everybody focusing on reflux, and instead understand that most of the time it's because they're gassy. I mean, they'll come in, on medications, and I'll say to the kid, "Does this kid spit up a lot?" "Oh, he spits up a little bit here or there." "Does he go to the bathroom?" "Well, no, he goes once every 4 days." Or he can still be going every 4 times a day, but either way, the kid's belly is distended, they're gassy and uncomfortable, and so a lot of times it's very simply just to try to get them to have more regular bowel pattern and get the gas out, and then many times you break the whole cycle. So with these colicky babies, usually a little bit of reassurance, getting gas out. Most of the time we don't do formula changes, with a couple of minor exceptions, and we try to stay away from reflux. So let's talk about reflux. The problem with the reflux happens in 2 circumstances. One, little babies who spit up a lot, and then older children. So in little babies, it's common. It resolves by itself. It's called physiologic reflux, and it's due to the muscles not being working in a normal pattern. Those patients, there's nothing to do about it. I mean, if they're perfectly fine and they're come in and they're spitting up, 20 times a day, and they're happy and gaining weight, and there's nothing works anyway. But basically, it just you don't do anything. They're fine, and it'll go away by itself. The older children are not supposed to have reflux. So once you get beyond a year or 2 years of age, then it's not normal. And so then if they're spitting up and having reflux, then by definition that's not a normal thing, and then you have to deal with it. The problem with reflux is that the people who take care of the kids with reflux are not kids. They're adults. And they project what they would think of to the kids. So that, for instance, I'm sure if I spit up 5 times a day, within about 2 days, I would have severe heartburn. I'd be uncomfortable, I'd be cranky, I take some medicine, I feel better, stop the medicine, it'd come right back again. That's adult reflux. That's not baby reflux. Baby reflux spits up 30 times a day and couldn't care less about it, and doesn't get heartburn, and doesn't become uncomfortable, and they're perfectly fine. So you have to remember that it's 2 different disorders. And if it persists in little babies, then that's due primarily to my friend the gas. If there's a lot of gas in there, again, the same thing. If there's not a gas in there, the stomach doesn't empty very well. Stomach doesn't empty very well, the food's got to go someplace. If it can't go down, it's going to come back up. So the kids who spit up a lot, usually they're spitting up because they're having some gas discomfort. And if you, again, treat the gas issues, a lot of times the discomfort from the spitting will get better. And they don't respond to medications or light, because the problem is not acid related, it's really more gas discomfort. So when we deal with functional disorders, or again, I'm quickly using that as IBS, you want to look at what happened in the past. The kid comes to see me with abdominal pain, and I say, what happened in the past? And I go, oh yeah, I was constipated beforehand, I had reflux beforehand. Or a little baby says, everybody in their family has chronic constipation, chronic reflux, chronic something or other. Then those sort of points you in the right direction. I always love to see patients who, I saw when they were babies, and I thought maybe they have IBS, and then I saw them again when they're 2, and I said they probably do have IBS, and then they come to see me when they're adolescents, complaining about constipation, or those are the greatest patients, because then you were right all along, and it's a consequence of the same thing. And many times you can get a hint about that by feeling the belly, seeing how much gas is in there, if there's a lot or a little, or if there's anything else that could be going on that could be contributing to it. I think it's important to not do too much tests. We do blood tests most of the time, primarily look for celiac disease, just because it masquerades as IBS. But most of the time, you don't need to do that. And then you have to understand that once you say you have functional abdominal pain, that doesn't get you off the hook. If you say you have IBS, that doesn't get you off the hook. That doesn't make the patient feel any better. You have to understand what's their manifestation of IBS. Obviously, a patient with constipation is going to be treated a little bit differently than the patient who's got diarrhea predominant. Or the patient who's gotten gas and bloating is going to be treated differently than than the person who's got diarrhea. So it has to be individualized a little bit, but it's all part of the same process where you have to individualize your treatment, and you can't just think it's a one-time proposition. You gotta follow them up. Because, again, you can get them out of the emergency room quickly, get the immediate pain better, but again, if you don't deal with the chronic thing, they're going to be as uncomfortable as they were beforehand, and obviously reassure them. And then the last thing is to know that the little belly achers are going to grow up to be big belly achers as they get older. And so this is all part of the same sort of disorder, and that, again, trying to individualize, understand it, help get rid of some of the things that are making things worse, like changing diet significantly. I say that, which is logical, but you think, but it doesn't, people don't realize that. If you're having a lot of gas pain, don't put extra gas into the intestine. Like the kids who come in to see me who are drinking, 3 bottles a day of seltzer. Then, obviously, what do you think's going into the intestine? And so you want to try to get them to having a regular, normal diet, physical activity, fiber, stress-free. Try to make sure that the 11th grade teachers aren't giving them too much homework, and then hopefully you can get them going so that you don't run into issues long-term with them. So that's sort of the overall view of functional disorders, and I'd be more than happy to answer any questions if anybody has, or specific issues. Ezra.
When is whatever it is, ileocolitis or whatever, when does that have to be done?
Well, so, what Ezra's asking about specifically is really Crohn's disease, which comes in a bunch of different names. And that certainly is always in the differential of patients who have, adolescents. The classical time for it to develop is somewhere young adolescents through the late 20s. So that's encompasses pediatrics and adults. And so you always worry about that, but most of the time it's generally pretty easy to sort out between a combination of exam and blood tests. And again, we're not talking about a one-time complaint. You're talking about people who've had stomach issues for a long time, and maybe it's a little bit worse recently. So then you're ready. You have somebody who's had some complaints for a while. You'd expect that it should be reflected in something other than just complaint, meaning blood tests are not normal. So usually we could sort that out before going to a lot of other tests by blood tests or whatever.
You mentioned fiber. What does that mean? Something from the drugstore?
Good question.
Or
okay.
That was my question.
Okay, good question. All right. So fiber. So fiber is fiber. There's no, yeah, people make difference between insoluble fiber and soluble fiber. I really don't make a difference about that. You look at a thing, and on everything it says how much fiber is in there. So fiber is good for everything that ails you, right? Fiber is good for cholesterol. It's good for heart disease. It's good for everything. But if you're taking fiber because you want to be healthy, it doesn't make a difference. I can tell you how much fiber you're supposed to take in a second, but it really doesn't make a difference. So if you take a little bit, you take some, breakfast, you take a good, some healthy fruits and vegetables and whatever it is, it doesn't make a difference. But if you're using fiber to treat the intestine, that's a different story, because those patients are really super sensitive. Remember that visceral hypersensitivity that I told you about beforehand? They're really very sensitive. So you have to be a little bit more rigid. So when I say fiber, I don't mean, going to the drugstore and getting some, just or eating healthy. I mean fiber supplements. And at least to start off with. And the reason that is that if you need for dietary fiber, the official term is you need 5 grams plus your age. So if you're, again, for kids. So if you're a 10-year-old, you need 15 grams of fiber a day. First of all, no 10-year-old takes 15 grams of fiber a day. No, I have yet, in being in the business for 30 some odd years, I still don't know whether that means I take into account what they eat or what I'm giving them. I still can't figure that out. So, but it means a lot of fiber. But if you're doing that dietary-wise, so what you're doing is you take a little bit of fiber for breakfast, and you take a little bit of fiber for lunch, and then you take a little bit of fiber for snack, and a little bit for dinner, and a little bit for a snack. So really what you're doing is you're taking low-dose fiber throughout the day, which adds up. If you didn't have an intestinal problem, that'd be great. But if you have an intestinal problem, really what you're doing is low-dose fiber throughout the day. And low-dose fiber throughout the day can cause more gas. That is why broccoli has a bad reputation. Broccoli has a bad reputation, not because there's anything wrong with broccoli. Broccoli is a low-dose fiber like everything else is. But if that's your only fiber that you're taking a gram, 2 grams of fiber at that meal, that's not enough. And the fiber draws the gas into the intestine, and it will make you gassier. So when I say fiber to treat the problem, I usually mean to sort of overdose with fiber, and that's fiber supplements. If you have a mild intestine problem and it's really not bad at all, then yeah, try dietary fiber and see what you're doing. And again, for adults, we think somewhere around 25 grams of fiber a day is about what you should be eating. And I'm a really big fiber fan, probably still don't get 25 grams of fiber in a day. So you don't have to be crazy about it, but again, I think it's important to know that sometimes low-dose fiber is not the best thing for you, so that, the choices are when you have IBS, either to eat no salad at all, because if you eat salad, you get gassy and uncomfortable, or to overdose it by using a supplement, and then you keep the salads all you want. It's healthier to do the latter.
Would stool softener help with gas?
Okay, so good question. The first thing is, I don't know what a stool softener is, because I'll tell you why. The intestine, if you go inside the intestine, it's liquidy stool. I mean, obviously, when we do colonoscopies, it's just liquid in there. Hopefully not too much, but it's really liquid. The stool, when it gets solid only when it gets down to the rectum, the lower portion of the colon. Where if it sits there, the fluid becomes drawn out of the intestine. That's how you sort of reaccumulate fluid, and you don't get dehydrated all the time. If it sits there too long, it gets too hard. And then you get rock hard stools, then you get impaction, et cetera, et cetera. So it's really more of a function of where the stool is sitting. Anything that's going to make the stool go quickly through there will make the stool softer and loose. So any laxative per se really is a stool softener to a certain extent. So Miralax, again, I hate it, but it still will make the stools loose. That's why we do colonoscopies. We use Miralax as a prep. Senna, which is what I prefer, will also, if you use enough of it, will make the stools loose. So anything will do that if you use enough of it, and the stool doesn't, and the stuff doesn't sit in the rectum. Does any of those get gas out? Well, gas comes out with bowel movements. That's what it's supposed to do. For instance, if your patients are gassing and they're passing gas at other times, that means that the previous bowel movement didn't do what it's supposed to do. Meaning the previous bowel movement is supposed to schlep out everything that's in there. If it doesn't, then you're passing gas at other times. So gas is supposed to come out with bowel movements. Laxatives per se won't necessarily make that happen any better. Of course, if you're going more, you're going to get more gas out. What fiber does is sort of traps the gas in the stool, so that when you then go to the bathroom, you get more gas out. The problem with fiber is that it's not a laxative, and a lot of times, if you're very constipated and all of a sudden you decide, oh, okay, I want to treat the constipation with fiber, you're actually going to get much worse. Because if you're not going regularly, the stuff is sitting there, and then you take fiber on top of it, it's not a laxative, the fiber just sits in there longer and draws more gas in it. So you sometimes need to use the laxative to get the stool out, and the fiber to get the gas out. So that combination we oftentimes use very well. So stool softeners per se do get gas out a little bit, except for Miralax. But again, fiber really does a better job.
Hi, so going back to the topic of infant reflux, I wanted to see if you could elaborate on when you would change formulas. You mentioned that you do that seldomly. When would you do that? When would that be?
Okay, good question. So one of the things in the differential about cranky babies is always allergies. Now, really, intestinal allergies in little babies, or what's called cow's milk protein allergy, typically has blood in the stool and a very healthy baby. Couldn't care less about it. They just have blood in the stool. So they're having regular bowel movements, they're not cranky, they're just having blood that you can see. If that happens, then there is potentially a role, not necessarily guaranteed, but potentially a role to change the formula. If the reason that you're changing the formula is not that, but instead is cranky irritability, that is not an intestinal allergy 90% of the time, unless the kid's not gaining weight. But that's not an intestinal allergy, that's more gas issues. So for those patients, changing the formula probably won't do anything, but can make it worse depending on which formula you use. Now, there are some formulas that are partially pre-digested. The two general formulas that I like the most are, for that purpose, are Alimentum and Nutramigen. People have problems with Hashgacha on them, but Nutramigen and Alimentum. And those work by sort of pre-digesting some of the milk protein that's in there, but also generally tend to have looser stools. So it's good for no matter what the problem is. If the problem is an allergy, it's partially treating that. The problem is more gas, the stools are going to be a little looser, you may get gas out better that way. So if you're going to change a formula, for whatever particular reason, that's the one formula I like the best. The formulas that I like the least are the more broken down formulas, like Elecare and Neocate, which have Hashgacha on it, unfortunately. But those formulas, because they're so well broken down, they do a great job for allergies, but they generally they make the kids gassy and uncomfortable. Because, again, gas comes out with bowel movements. If you don't have good bowel movements, you're going to have more gas. And because these formulas are so well absorbed, nothing is coming out. They have these sort of sticky, greenish, gooey bowel movements, which don't get gas out. So therefore, you get a kid who's got a little bit of blood in the stool and very cranky, and you put them on Neocate because you think it's all from an allergy, and the blood goes away, but they're even more uncomfortable. So that's where I think you have to be careful about which formulas you use. I mean, there's so many formulas around that most of the time it doesn't make any difference. But when you start going to more of the specialized formulas, sometimes they're helpful and sometimes they actually can make things worse.
Follow-up question to that. So what do you think about the formulas that add thickeners to
Okay,
so
good.
like, you know, so I ordered one from Germany called HIP anti-reflux.
Yeah.
I think it seems to be working, so I want to know what you
Right.
think.
Well, again, the Levine model of most of what's going on, as you can see in the intestine, is related somewhere or another to gas, whatever it is. So if you take a little kid who's having gas pain and you put cereal in there, it becomes harder to have bowel movements. They oftentimes get constipated. And so therefore what happens is they get more gassy and more uncomfortable. So these kids who come in, you know, oftentimes they're spitting up, as most babies are. They're spitting up probably a little bit more because they're gassy. And so you think that, okay, they must have terrible reflux. It's so bad that it doesn't respond to the medication. And therefore I must use a formula that's going to make the reflux better, like a thickener, like the thickened formula. And therefore what happens is they spit up a little less, but they're even more cranky. So that's where I think trying to understand, you know, what is going on about these kids, especially when you're related to the little babies and the reflux issues, make it a big difference. I always sort of smile, you know, the kids come in, they're irritable, they're cranky, they're on famotidine, they're on Prevacid, they're on something or other, which has never been proven to be safe in kids, parenthetically. But there are these medications. They're still cranky. They're told they have the world's worst reflux. And I say to the mother, just out of curiosity, how often does the baby spit up? Oh, the baby spits up a little bit here and there. And I sort of smile and say, oh, the esophagus in little babies is this long. So if they have such bad reflux that they don't respond to medication, they don't respond to formula changes, whatever it is, why aren't they spitting up 100 times a day instead of a little bit here or there? It just doesn't make logical sense. And then, of course, the gassy and uncomfortable, et cetera, et cetera. So I don't use the thickening formulas because I think that's sort of not addressing what the underlying problem is. Even if you're dealing with an older patient who you think the reflux is significant, just thickening it doesn't, you should find out why they're having such bad reflux that requires treatment. Where in general, most babies or kids up until age 2 don't require any treatment whatsoever. No, not good. Obviously, it does get better. Some patients do get better. So, I mean, I'm not, nothing's perfect, but.
My child has celiac, and I'm very, very careful with very little milk and everything. But how much does the paranoia have to be? Like, because, the rest of my household is not celiac. So, I'm constantly washing my hands and changing gloves, but I just want to know from your.
You want to know the answer? You don't want to know the answer, do you?
No. I do want to know that. I'm doing the most, but I just don't know.
Yeah, you have to be paranoid.
Can you tell me why?
Okay, so celiac disease again, which is it's not an allergy. Again, so if you're allergic to dairy, as an example, if you're allergic to dairy, and if you take a lot of dairy, you break out in hives and you have vomiting or whatever it is, and if you take a little bit of dairy, you don't break out in hives and don't have vomiting, so just take a little bit and don't take a lot. Celiac disease is not that way. Celiac disease, it's sort of, I sort of think of it as being pregnant. Either you're pregnant or you're not pregnant. Either you're treating it or you're not treating it. Meaning, if you're treating it partially, it's as if you're not treating it. What does that mean? So there's 2 reasons to treat celiac disease. There's the immediate issue, whatever it is that made them think they have celiac disease, which many patients don't have. So but the kids who have abdominal pain, they're not growing well, whatever the reason is. That immediate issue, obviously, if you then got them off gluten, they'll do better. Even if you got them off 90% gluten or 75% gluten, they'll probably do better. But the more important reason you're treating celiac disease is to prevent the complications. The complications happen because of the underlying inflammation that's going on in the intestine, which you don't know about. And that there is there's a list of about 30, if not more, diseases that are associated with untreated or undertreated celiac disease. So, therefore, you want to be perfect. It could be perfect, you can't be 100% perfect. And not only that, we don't even know if you're perfect or not because we rely on the blood tests to tell us that, and the blood tests probably don't tell us 100% what's going on in the intestine. It's the best thing we have, short of doing another endoscopy. So I think it's important, especially in kids, to be aggressive as far as treating it. And one of the things I'll close what celiac is about is that one of the primary effects of celiac disease is it prevents the absorption of calcium into the bones. Now, any of us, the only time we get calcium into our bones and build strong bones is through puberty. Once past puberty, whatever's in there is in there. There are now medications that older patients who have osteoporosis can use, but primarily whatever's in there is it. And so that if you allow untreated celiac or undertreated celiac disease through puberty, you're probably setting patients up for long-standing bone disease when they're 40s and 50s and 60s. So at least through puberty, we're pretty nasty. After that, then the adult people are a little less rigorous in that. Okay.
Could I ask a celiac disease question?
Sure.
I think a few of us here are here because of that. If a child was diagnosed and it's been a while and the blood work is good, and if I speak to a lot of mothers, there's still child complaining about stomach pain. Do you see that a lot in your practice? And if you do, is there an like arching through that you see that helps a lot of the patients? Like how can we,
Fiber.
yeah.
I mean, again, celiac disease inherently, the gluten-free diet is not an unhealthy diet. It's a healthy diet. The problem is that most patients don't focus specifically on the healthy part of the diet, and they spend a lot of time on just making sure that it's gluten-free. And so, therefore, a lot of times you get IBS as part of and pain and that kind of stuff because you're not focusing on the fiber and that kind of stuff. You're just focusing on the gluten-free part of it. So it's very common for us to take patients who have celiac disease and put them on fiber. You have to make sure you put the right fiber because some fiber has gluten in it. But so a lot of times we put them on fiber just because they're complaining a lot, whatever it is. But again, you have to be sure nothing else is going on. Obviously, be sure the celiac disease is under control. That kind of stuff.
Okay. Thank you, Dr. Levine.
My pleasure.
Thank you. Good, appreciate it.
No problem.